My task is to talk about psychopathology of emerging psychosis and a little bit also touching on what we do in Basilea, in Basel, or however you call it. It's in Switzerland, just at the border to Germany and France. And we have built a clinic for early detection of psychosis there in 1998. And I'll show you a little bit what we do there. It's also a nice town, as you can see here. So now I tried, first of all, a little bit about emerging psychosis. What do we know? I can skip that more or less because all the previous speakers have told you about that. Then I show you what we do in Basel, and then I'll go in details about psychopathology of the at-risk mental state patients, and I'll show you the differences, if there are any, between those at-risk mental state patients who will later on actually develop psychosis, make the transition to psychosis, and those who won't, and the first episode patients. And if we still have time, I also show you the comparison to emerging depressive diagnosis. So, technique, this way, okay. You have seen that from in other slides. We know for quite some time now that psychosis does not start all of a sudden with frank delusions and hallucinations, as I still learned when I was a young psychiatrist. But then I was in a research group in Mannheim together with Heinz Hefner, and there we looked into the details of emerging psychosis. Really, we got this idea from Gerd Huber from Bonn, who was one of the first who had described that there are much earlier than delusions and hallucinations, there are these prodromal symptoms and basic symptoms. And when I was studying psychiatry, I was very interested in reading his book, and then when I was in Mannheim, I thought we could look at that as well. So we constructed an instrument called IRAUS, which also included all these prodromal symptoms and the basic symptoms. And there we could show for the first time, not only in a clinical population, as Gerd Huber had done, but in a representative population of all first admitted of a catchment area of 1.5 million people, based on 392 first admitted patients with schizophrenia and schizophrenia spectrum disorders, that it is really true that these disorders start on average about 5 years before frank psychosis really has its onset. And what was really interesting, we asked the patients, what was the first time when you realized you were not the same person anymore, when you realized a change with yourself, something going on with yourself. And almost all the patients could tell you quite exactly when that started. And they could still tell you how it started, how they realized that they were not really the same people anymore. And so based on that, then Pat McGorry was visiting us also as a young researcher, and he said, this is great, and what you do here retrospectively, I will do that prospectively in Australia, and he founded the first early detection clinic then there. So, what I did then as well when I came to Basel in 1998. We founded the early detection clinic first. You can go to the website and see what we did. We did big information campaigns with the psychiatrists in private practice, with the GPs, but also in the lay media, in the newspapers, television, and so on, telling about how psychosis really starts. You see here, this is how our website looks in the meantime. We did this self-screened instrument. We put that on our website and we distributed it everywhere, and in every lay media article you can screen yourself whether you have a psychosis risk or you can. And some patients came up to our clinic themselves, or in other instances I had, for example, talks in front of teachers how they should recognize beginning psychosis in their pupils, and then at the end of the week, one of the teachers came up and said, I think I have that, could you test me? So people came based on these instruments. And also we did this risk checklist for psychosis. That was for the psychiatrists, more or less. And what it says, I show you here to read a little bit better, that you really, as a psychiatrist, or maybe even as a GP, if you have the feeling for these sort of things, you have 6 symptom dimensions you have to look for in order to recognize whether this person maybe has a risk for developing psychosis. First dimension is changes in personality. If this person tells you that he has gone more sensitive, more irritable, more nervous, especially more sensible also towards other people. Everything is somehow going under my skin. That's what patients in German often say. They do not have these clear borders to the outside anymore. They get very touched about everything. Then loss of interest and initiative, self-neglect. The second complex is changes of affect. These patients very often make the impression that they develop slight depression, but it's not really a deep depression. It's more a sort of affective flattening. And they have, more or less all of them have some sort of anxieties in, like, I'm getting mobbed, or these people are not nice to me anymore, what do they want from me? Then what is very important as well, changes of performance. A very old psychiatrist in Heidelberg described the beginning of psychosis as kink in the lifeline. There is this lifeline, which in young people usually goes up and up and up. They find a partner, they finish school, they go get a job. And then in these people with emerging psychosis, all of that all of a sudden drops, kink in the lifeline. So this was very interesting for us, and this is what in modern psychiatry is, of course, called loss of functioning or something. But the kink in lifeline is in our clinic is something which we were very impressed by. Then loss of concentration is very often what is behind that. Loss of concentration, especially selective attention cannot be remained anymore. If many people talk, these young people cannot concentrate anymore. Social changes, very interesting, very often suspiciousness, increasing social withdrawal, relationship problems, changes in interests. We had quite some patients who all of a sudden got interested in religious sects or esotericism, people who were never interested in these things beforehand. Then all of sudden changes in perceptions, some peculiar experiences, unusual perceptions, colors are more intense. I hear so much louder, I must close my ears, things like that. And then slowly, things of referring things to oneself, I'm getting influenced. So this was the checklist, and this was how we trained the psychiatrists. If you see this in your patients, please send them to our clinic. And then 1 year later, we also started our research project and wanted to have a look whether that was a really good idea, what we had presented them based on the literature. These early prodromal symptoms, whether they are really correct and good predictors. So what we did, we examined all the patients who were sent to us with very intensive psychopathological screening, history taking, but also neuropsychology, neurophysiology, neuroradiology, and endocrinological lab. And we devised a screening instrument because the CALMS, which was used in Melbourne, then was not published yet, but we devised this own screening instrument which checked for the criteria of the Melbourne CALMS, but is a bit shorter, better there is a better handling in the clinic because it is shorter, but you can check all the criteria of the CALMS, whether this patient is a patient at risk or not at risk, or even already has got a frank psychosis. So what you test in this instrument is also mainly psychopathology, this social decline, previous psychiatric history, genetic risk, and so on. And then based on that, you can tell whether this patient has already met the inclusion criteria for being at risk for psychosis. I don't go into detail. I think you all know that. These are the pre-psychotic, attenuated psychotic symptoms. It's a sort of sub-threshold psychotic symptoms, or brief, limited psychotic symptoms, or the genetic risk together with some other symptoms, but they are not frankly psychotic already. And then there are also the clear-cut transition criteria. From when on can you say this patient is really psychotic, has fulfilled all the criteria for antipsychotic treatment, really. That's the clinical use of it. Now, in the meantime, we have screened around 650 patients who were sent to us or came on their own with the question of a risk for psychosis. And what you can see here, of these 655, 130 already were frankly psychotic and in need of treatment, antipsychotic treatment, and of course psychosocial treatment as well. Sorry. Sorry, 275 were frankly psychotic. Of those, 130 agreed that we could examine them extensively. 271 were at risk, according to our instrument, and 109 neither had psychosis nor were at risk. They had some other diagnoses. And of those at risk, 173 agreed to participate in a long-term assessment with us. So they got intake examination, a very extensive intake examination, and then they were followed up over at least 5 years, if possible. And now, as promised, I show you the psychopathology of the at-risk mental state patients. And what we did here is, this is what you probably don't find in other studies. we said we want to compare the converters, those who made the transition to psychosis, with the non-converters, those who did not make the transition to psychosis. And usually it's a sort of split half or so, or something. What we said is there is a group in between which we don't really know yet whether they will make the transitions to psychosis. These are the ones we have only observed for less than 3 years, because in our first analysis, in the first years, we saw that if a patient makes the transition to psychosis, it's usually within the first 3 years. And if you compare the extreme groups, transition, non-transition, you really must leave this middle group out. You can't analyze them. And if we compare the converters, those who made the transition to psychosis, with the true non-converters, as we call it, we saw that within this group, who all had these risk criteria fulfilled according to our instrument, there still was a difference in between those who later made the transition and those who did not. This was especially suspiciousness. Those patients who already in the beginning had been very suspicious had a much higher risk of later transition, even within this group where all of them were more or less prodromal, had prodromal symptoms. And also the conceptually disorganized had a slightly greater risk for later decompensation. And what also is interesting, and this was found in other studies like the Naples in the States as well in the meantime, that it is not the positive psychotic symptoms or the attenuated psychotic symptoms only which predict whether somebody will later make the transition to psychosis, but it's also the negative symptoms. You see here, global rating of anhedonia as sociality was higher in those who later made the transition, and it was especially the items relationship with friends and peers, and ability to feel intimacy and closeness. So if a patient at the first visit to you has a bad scoring in these items, tells you this has really deteriorated recently in these instruments, then this is a warning sign. He might have especially high risk of transition. Also, cognitive testing was interesting. There were, as you see here, those with later transition had more cognitive decline, had worse cognition than those without later transition. This was especially true for non-verbal IQ and for working memory, certain tasks of working memory. And if we put all these together, we saw this is this usual ROC curve, receiver operating characteristics. We saw that if you only use brief psychiatric rating scale, positive symptoms, or only use negative symptoms, or only use neuropsychology, you can improve the prediction step by step. But if you use all these instruments together, the prediction of later transition is the best. So you should use positive symptoms, negative symptoms, and neuropsychology together. And here again, you see the most predictive variables within that prediction model were, again, suspiciousness, asociality, anhedonia, working memory, conceptual disorganization. 5 minutes. When we ask the patients themselves, we always are very keen to ask the patients themselves, self-experience things. What was the main reason, why did you come in the beginning to see us, our special clinic for early detection? And you say, oh, this is really because of this. It's really interesting that almost 60% of the patients said self-recognized change in state of health. So this is a real chance of early detection, that in the beginning the patient really realizes very often that there is a change in mental health. And only later on, when he is delusioned and frankly psychotic, he doesn't accept anymore that this is an illness. So if you can get in touch with these patients in these early stages, this is the chance to build a good relationship and go in a therapeutic process and prevent deterioration. Onset of peculiarity, that's what they said. And some also came because of attempted suicide, but this was rarer. And the very first self-perceived symptoms, we asked them, when did you first notice this change? That was feeling depressed, not able to feel joy anymore, withdrawal, avoiding contacts, unusual difficulties concentrating, very important, unusual anxieties and fears, loss of energy. So, just briefly, we thought in the clinic we very often have this problem. Now, when this patient looks slightly depressed, the GP sends us, this is a depression, please treat the depression. And we then think, well, might this be a prodromal patient at the same time, and how can you differentiate it? This is why we compared our at-risk mental state patients with depressive patients. And we asked both of them what was the first self-perceived sign of their change. And you see here only a few differences really. The green one are the depressive controls, and the significant differences were really only 2 items. This withdrawal, avoiding contacts, was even more in depressed patients, and what is really very impressive, they did not at all say that it started with unusual anxieties and fears, the depressive controls, but this was very often the case in the at-risk mental state. So my conclusions: reliability of diagnosing an at-risk mental state, of course, has to be improved. A lot of researchers work on that. Psychopathology can contribute to that. If you really do a very good psychopathological testing and have good clinicians with a lot of experience, they can really detect to quite some extent whether this patient has got some prodromal risks. We should not only assess attenuated psychotic symptoms, but also negative symptoms. And what I didn't show you the data, what we of course also do is, apart from neuropsychology, we also do MRI, EEG, quantitative EEG, endocrinology. So if you combine all these data in the end, and this is what Stefan Roman already showed you, done in big multi-center projects, combining all these data, we should be able to do much better, more exact prognosis and tell the individual, like in internal medicine or in cancer research, this is a slight risk for you, we just observe it, or there is a moderate risk for you, we want to have you in therapy, psychotherapy, social therapy, stress reduction, stress coping, and so on. Or there is a high risk, we want to see you every week, and of course always psychoeducation and taking the patient as a partner, making an alliance with him, giving him a good feeling for his own prodromal symptoms and how to recognize it and what to do when it gets worse.